Different common radiological procedures which are used for diagnosis of chest disease are: number one is tele-roentgenography, which is the commonest of all. X-ray chest is taken either PA view, in which the rays come from the back of the patient at a distance of 2 meters and the X-ray is in front of the chest. The heart and lungs are more clear than the bones because they are near to the anterior plane. In AP view, the rays come from the anterior and the X-ray film is placed at the back of the patient. In this film, the vertebrae and posterior part of the wrist are more clear. Second is tomography. In tomography, images are taken from different depths of the chest. In fluoroscopy is the medical imaging test that uses continuous X-rays to show real-time moving images of the inside of your body, much like an X-ray movie. Unlike standard X-ray, which takes a single photo, it leads doctors to watch organs, blood flow, and medical tools in action. The fourth is sign radiography. A film is prepared during fluoroscopy and angiography. In angiography, radiopaque drug is injected through catheter into the various chambers of the heart and coronary arteries to study their abnormalities. To examine an X-ray chest, we have to look for first the bone is skeletal, look for kyphosis, scoliosis, any crowding of the ribs or localized widening. Second is position of the patient. It should be quite straight. The medial end of the clavicles on both sides should be equidistant from the spines. If it is not, the patient is tilted towards the lesser distance and X-ray should be interpreted in that reference. Then position of the trachea. For position of the trachea, we have to see in the superior mediastinum. A dark column is seen containing air because air is translucent, and trachea is seen as a dark column in the center of the superior mediastinum. Sometimes the two bronchi can also be seen originating from trachea. The outline of the heart and mediastinum, diaphragm, and lungs will be discussed in the next slide. This is exercise PA view. Both lung fields are divided into three zones. Upper zone is from the apex to the lower border of the second costal cartilage. The middle zone is from the second costal cartilage to the lower border of the fourth costal cartilage, and the lower zone is from fourth cartilage to the diaphragm. We have to look for the costophrenic angles on both sides, the cardiophrenic angles, and the heart and mediastinum, heart in the mediastinum. Coming on the left side of the mediastinum, from above downwards, the upper is the knuckle, aortic knuckle. Then is the pulmonary conus for pulmonary artery. Then the space for left atrium, and it's then left ventricle. On right side, the uppermost is the superior vena cava, then right atrium, and lower down it is the inferior vena cava. These are both diaphragms, both sides. The left diaphragm is slightly above the right diaphragm. X-ray chest APU. In this, the vertebrae and the posterior part of the wrist are more clearer than the lung and heart shadow. To measure the size of the heart, whether it is within normal limits or enlarged, the distance from one costophrenic angle to another is measured, and the maximum diameter of the heart is recorded. And we have to see if this distance is more than half of this, then the heart is said to be enlarged. For examination of normal contour of the heart, particularly in fluoroscopy and angiography, the views used are: number one is the posterior anterior view, right anterior oblique view, left anterior oblique view, and lateral view. To look for left ventricular enlargement, PA view is taken left anterior oblique view and then left lateral view. For right ventricular enlargement, posterior anterior view, left anterior oblique, and left lateral view are observed. For enlargement of the left atrium, posterior anterior view, right anterior oblique, and left lateral views are observed. For enlargement of the right atrium, PA view, the heart is examined in PA view and left anterior oblique view. This is how the different chambers of the heart look like in PA view. This is PA view. This is right anterior oblique view. This is left anterior oblique view. The different chambers of the heart, how they look like. And this is left lateral view. Then we come to the pneumonias. There are two types of pneumonias: lobar pneumonia and bronchopneumonia. The lobar pneumonia is a uniform consolidation of an entire lung lobe used to share bacteria due to severe bacterial infection that causes inflammation and fluid buildup in an entire lobe of the lung. The bronchopneumonia or lobular pneumonia is characterized by patchy, scattered inflammation centered around the bronchioles and surrounding the alveoli, that is the air sacs in the lungs. These are the lung lobes: upper on the right side, upper lobe, middle lobe, and lower lobe. On left, it is the upper lobe and the lower lobe, and in the upper lobe is the lingula, which represents the middle lobe of the left lung. This is pneumonic consolidation in right upper zone, and this is lingula consolidation in left lingula. And again pneumonic consolidation upper part of the lung, right side. This is pneumonic consolidation. This is typical bronchopneumonia. Bilateral scattered small opacities and marked bronchovascular markings. This is bronchopneumonia. The common organisms which give rise to pneumonia are Streptococcus pneumoniae, Haemophilus influenza, Staphylococcus aureus, Klebsiella pneumoniae, Actinomycosis sterile, primary viral pneumonias, Chlamydia psittaci. Suppurative pneumonias, aspirin pneumonia, and pulmonary abscess. Pulmonary abscess is a localized pus-filled cavity within the lung tissue surrounded by inflammation. It is a severe condition that causes breakdown and death of lung tissue through liquidated necrosis. The most common cause of accidentally inhaling food. The most common cause is accidentally inhaling food, saliva, or stomach acid into the lungs. The, this frequently happens during periods of altered consciousness, that is during anesthesia, sedation, or during alcohol intoxication. Suppurative pneumonias and abscesses often develop after inhalation of septic material, during operations on the nose, mouth, and throat under general anesthesia, or vomiting during anesthesia or coma, particularly if oral hygiene is poor. Additional factors for aspiration pneumonia include bulbar or vocal cord palsy, stroke, achalasia, or esophageal reflux, and alcoholism. This is pulmonary abscess, thick walled cavity with an air, air level is seen inside. There is fluid into the cavity. The fluid level is seen as a straight line. Then pleural effusion. Inflammation of the pleura is known as pleural effusion, and it can be exudative or transudative. The exudative pleural effusion is due to tuberculosis, malignancy, collagen disorders, and pulmonary infarction, while transudative is due to cardiac failure, hepatic failure, and renal failure. To exclude exudate from transudate, if a pleural fluid protein serum protein ratio is more than 0.5, if the pleural fluid LDH ratio is more than 0.6, and if the pleural fluid LDH is more than two-thirds of the upper limit of the normal serum LDH, then it is exudate. The simplest formula is that if the serum protein is more than 3 gram per 100 cc is exudate, if it is less than 3 gram per 100 cc is transudate. This is pleural effusion. The right calcium-forming angle is obliterated and with the opacity likewise, oblique line likewise, the whole space is filled. This is pleural effusion. Then spontaneous pneumothorax. This can be primary with no history of overt lung disease or subpleural bullae or blephs are present, or it may be secondary to lung disease like COPD, tuberculosis, chronic asthma, lung abscess, pulmonary infarcts, bronchogenic carcinoma, all forms of fibrotic and cystic diseases. This is pneumothorax on right side. This space is filled with air and the lung on the right side is collapsed. This is the right lung. Pneumothorax left lung. This is all air and the lung is collapsed, left lung. This is the collapsed lung. Hydropneumothorax, that is the air plus fluid. The fluid level is seen in the form of a straight line. This is air and this is the fluid with the fluid level. This is known as hydropneumothorax. Chronic obstructive pulmonary disease. The pulmonary component is characterized by airflow limitations that is not fully reversible. Related diagnosis includes chronic bronchitis, cough and sputum, most days for at least 3 consecutive months for at least 2 successive years. Emphysema, that is abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis. The extra pulmonary manifestations include impaired nutrition, weight loss, skeletal muscle dysfunction, peripheral edema, and osteoporosis. This is typical picture of COPD. The lung fields are hypertranslucent due to trapped air. The heart is elongated. The diaphragms are depressed. This is typical COPD, tubular heart, hyperlucent lungs, and the marked bronchoscopal markings on both sides. Factors which lead to COPD are tobacco smoking, biomass, solid fuel fires, wood animal dungs, crop residues, and coal. Then coal miners and those working with cadmium. Outdoor, indoor air pollution, low birth weight, persistent infections, usually adenovirus, low socioeconomic status, nutrition, and cannabis smoking. In investigations, X-ray chest is not much specific except that tall stature, normal heart, and increased translucency in both lung fields, forced volume in 1 second, forced expiratory volume 1 second is less than 80% of the predicted value. Forced expiratory volume in 1 second, oblique, full vital capacity is less than 70%. Blood CP, alpha 1 antiproteinase deficiency, high resistance computerized tomography is most reliable. Then bronchiectasis, abnormal dilatation of the bronchi due to chronic suppurative airway infection with sputum production, progressive scarring, and lung damage are present irrespective of the cause. Etiology, congenital defects affecting airway and transport or ciliary function such as cystic fibrosis and Carter-Jenner syndrome, that is sinusitis plus transposition of the viscera, and second is secondary to damage to the airways by a destructive infection, inhaled toxins, or foreign bodies. Third, localized bronchitis may occur due to accumulation of pus beyond the obstructing bronchial lesion, such as enlarged tubercular hilar lymph node, a bronchial tumor, or inhaled foreign body, such as aspirated pea nut. This is a typical X-ray of bronchiectasis. The dilated cysts are seen. Cystic rings are seen in both lower zones of the lungs. Cystic rings. This is a typical diagnostic of bronchiectasis. Again, cystic appearance on left side, right side, mid and lower zones mostly. Radiological examination in advanced cases, thickened airway walls, cystic bronchiectatic spaces, and associated areas of pneumonic consolidation or collapse may be visible. Computerized tomography is much more sensitive and shows thickened dilated airways.